So part of what you do is coordinate with the orthopedic department.
Correct.
So for you, is it it's two hats basically that you're wearing? You have an administrative hat and you've got a medical hat, right? Kind of like the business aspect of things and then the art and science aspect of things.
Right.
Did the two ever come into odds with each other? Does the doctor and you sometimes want one thing while the administrator is coming from a different place?
Not really. I mean, there's really not a lot of administrative stuff to be done in my capacity there at the hospital. It's a smaller hospital, so it's not as complex for me. So fortunately, I can devote a lot more time to really just being a surgeon and taking care of the patients.
Sure.
Which is the best thing. I mean, there obviously are administrative things like basically credentialing and things like that you have to do. But for the most part, it's actually not. It's not as complex as one would imagine.
Has there been? There has to have been. I mean, I'm asking, has there been? But I've seen the growth at North Shore Plainview in particular from what it used to be, even 10, 15 years ago to the facility that it is today. It's definitely morphed into something that's a lot more technically oriented. You're probably handling a lot other newer, different kinds of cases than you used to.
I think that North Shore Plainview is actually one of the best kept secrets on Long Island.
I agree.
Personally. It used to be called Central General.
Right.
It didn't have the reputation it did now that North Shore took over the management of the hospital. It's a fantastic hospital. We have an amazing operating room staff there. The surgical technicians that help us in the operating room, the scrub techs, are really, I think, among the best on Long Island that I've worked with.
A great nursing staff also. I mean, unfortunately, I know from personal experience, I wasn't there for anything serious, but I have been a patient in that hospital, and the whole environment there, it's very home-like. It feels manageable. It feels comfortable.
Well, it's nice when you walk in because it's carpeted. And you actually feel like you're in, and it actually looks like a big living room when you walk in, which is very nice for the patients. They have a very nice coffee shop, which makes good food.
Yes, I remember the food wasn't so bad.
And the nurses are really terrific, particularly on the orthopedic spine floor that we have. And the physical therapy department really is quite good.
Which is key, I would imagine, especially after your particular kinds of surgery.
Yes, absolutely.
So the patients have the operations and they're beginning their therapy while they're in the hospital before discharge, and then I guess they get referred for rehab further after they're discharged. Well,
it depends on obviously on how they're doing. Some of the older folk who have the surgery sometimes require basically a transition between the hospital and going home, so they end up going to rehab. More of the younger people usually are able to get home with home physical therapy. But we try to. The goal of particularly back surgery is really to try to get them out of bed the next day if we can. I always tell patients what your goal is to try to at least get out of bed at some point the next day into a chair.
What is post-surgery? And you mentioned before that this unfortunately can be a painful procedure that people go through. What kind of pain management are you dealing with?
Basically, if patients come in with severe back and leg pain, you hope that after the surgery, they're really left with incisional pain, which is to be expected.
And that at least is passing.
Right. That's something that usually gets better as time goes on over the next few weeks. But what we do to try to deal with that is we oftentimes will enlist the help of some of the pain management specialists.
And you have that on staff in the hospital? We
have that on staff at the hospital. There is a group of pain specialists at North Shore that work at North Shore Plainview who will come over and really manage the pain managements, particularly the narcotics that people require after this type of surgery. Basically, depending on how big the surgery is, sometimes patients can just get away with shots. Sometimes they actually need a narcotic pump, like a morphine pump, that they actually can deliver their own medicine themselves to control their own pain. And that's usually managed by either the anesthesiologist or one of the pain specialists who are actually anesthesiologists who come over and help them.
Is there a typical length of stay for most of the procedures that you're performing, or does it vary widely? It
can vary. It depends on what the patient's having done. If the person comes goes in to have just a simple disc removed from their lower back, usually they can go home the next day. If a patient actually has what we call a lumbar fusion or a big operation that requires what we call instrumentation or screws and rods, things like that, those patients can be in the hospital anywhere between three days to a week.
Wow. I'm going to ask you in just a minute about how insurance might have been affecting that over the last couple of years. I just want to remind everybody that they are listening to Island Outlook on the stations of the Long Island Radio Network. Insurance is a big factor for everybody these days, and what I'm hearing from lots of folks that I've discussed issues like this with is that the length of stays have been shortened, not necessarily because the doctors and the patients would like it that way, but insurance is covering far less. Has that impacted you at all?
Yes, because basically what it has done is it's basically forced the hospital to develop teams of people who come and actually review the charts and the length of stays the patients have. So there's pressure to try to get the patients out of the hospital as soon as possible. Now, obviously, we all want that because, as you know, in the hospital setting, there's always a possibility for what we call nosocomial infections or infections that can occur while being in the hospital because of just the environment.
Sure. So I guess it's a mixed bag, kind of. There's some positives to leaving the hospital early, and then there can potentially be some negatives as well.
Right. Basically, the way I deal with this is that I say to my patients, when you are ready, you will be discharged. And I have to be the final say in if a person comes up to me and says, why can't this person be discharged today? If I really feel that they can't, I'm not letting them go. And basically, I have to be aware of that and also document why they have to be in the hospital another day, and that's usually worked out. So
you don't get hassled too much by the insurance in that instance.
Correct.
Which is good to know.
Right.
Yeah, definitely. So in addition to the work at the hospital, I know you're also a member of a private practice with Neurological Surgery PC. Tell us a little bit about the group.
Well, the Neurological Surgery PC has been a practice that's really been established for about 50 years already.
Wow.
It was first started by a Dr. Mel Greenberg, who basically has since retired, but still around and quite kicking. And subsequently Dr. Stephen Burstein and Dr. Mihai Dimachescu were the two doctors who were also part of the group for many years. The group was mainly centered in the South Shore, had a South Shore presence, but also did work in the North Shore, but more in the South Shore. And they hired myself and Dr. Michael Brisman, my partner, 13 years ago. And since that time, Dr. Dimachescu retired, but Dr. Burstein still remains and is quite active. We've hired really quite a few new doctors to our practice. We have over 20 doctors now in our practice.
Yeah, it looked to me while I was doing a little bit of research on the group that you guys have grown by leaps and bounds.
We have grown tremendously over the last few years. We've hired the whole gamut of neurosurgeons that cover all types of diseases, including vascular, tumor, functional. We have wait. So it's not just brains and spines. It is basically brains and spines, but in terms of
the different
specialties of neurosurgery.
Okay.
We now have basically doctors that specialize in brain tumors, doctors who specialize in taking care of vascular problems, functional pain type disorders, epilepsy, and we also have pediatrics now we've added, which we traditionally did not offer, and we've hired a pediatric neurosurgeon as well to basically handle those sort of problems. In addition, we've also have hired neuro-oncologists to help manage the perioperative and also basically medical management of patients with brain and spine tumors, and also we've hired some physiatrists who actually do pain management, injections, epidurals.
Right within your own group.
Within our own group, we have hired a neuro-ophthalmologist to take care of patients with diseases that affect the eye, that neurologically affect the eye.
Neuroblastomas, things along that lines.
Things like that, pituitary tumors, and in general, just problems that can affect the eye as well. And we've also hired a neurologist who specializes in epilepsy.
Wow.
and now we take care of epilepsy patients as well in the hospital.
So you don't just have that one office anymore.
So we just don't have that one office in that basement office in Freeport anymore, which I first started out at. We actually have, right now, I think we have 6 offices in Nassau and Suffolk County. We have offices in Great Neck, Lake Success, Rockville Center, Port Jefferson.
There'll be a quiz.
Comac? What's it?
There'll be a quiz.
That's true.